And good morning, everyone, and welcome to Internal Medicine Grand Rounds. And it's my pleasure today. I'm Dr. Kim Allen Williams, Chair of Medicine here at University of Louisville. And this is a unique pleasure for me to have a speaker who was my resident, and I think you were my intern too.
Yeah.
Right, yeah, indeed, indeed, at University of Chicago many years ago. But I don't get the honor of introducing him because today is a very special day. Today is the 2025 Beverly Todd Towery Lecture, and that's always presented to us annually by the Division of Endocrinology. Therefore, I get to introduce Dr. Sri Mukshgundam, who is our division chief and professor and a wonderful leader here, and he will introduce our speaker. Thank you, thank you, Sri.
Thank you, Dr. Williams. It is my pleasure to give a brief introduction of Dr. Towery and also introduce our speaker. The Beverly Todd Towery lecture was set up in honor of Beverly Todd Towery, who set up two divisions of endocrinology, one at Vanderbilt before he moved to University of Louisville as chairman of medicine. He was a towering figure in the field of endocrinology and medical education. He served here as chairman of medicine from 1956, I think until 1970 or 72. This lectureship was started in 1982, so we've had it for a long time. Another interesting thing is that the last fully in-person grand rounds in medicine was the Towery Todd lecture in 2020. After that, we were either virtual or hybrid. So Richard Dawkins, that was in 2020 that he came and gave this lecture. Today, we are pleased to have Dr. Robert Sargis from the University of Illinois. He is a physician scientist who has made significant contributions in the field of environment and obesity and diabetes. He obtained his graduate degree in chemistry from Carleton College. He went to medical school with his MD and Ph.D. at the University of Chicago, at Rush, and then he did his residency and fellowship at the University of Chicago, where he joined as a faculty member and moved to University of Illinois in 2021, where he is currently associate professor and chief of the section of endocrinology at the Jesse Brown VA Medical Center in Chicago. He's an outstanding clinician, educator, and researcher. His clinical practice primarily focuses on obesity and lipid disorders. He has made groundbreaking contributions in his research field, which focuses on understanding how humans and alter their environment and how those alterations promote the development of metabolic disorders such as diabetes, obesity, and fatty liver disease. He has been funded by the NIH, the VA, and the Department of Defense, and several other agencies. His findings serve as a foundation for public policy changes that will help mitigate the impact of environmental toxins on vulnerable populations. In addition to numerous publications and awards, he has also been working to raise awareness of these findings among policymakers and the public, which I think is as important or more important currently. He hopes to leverage sound science to improve clinical and policy efforts to address the deleterious effects of environmental pollution on human metabolic health and its disproportionate impact in vulnerable populations. And today's topic really focuses on this, and we will hear about it in a minute. Dr. Sargis.
Thank you so much. And thank you, Dr. Williams, and it's great to see you. It's great to absolutely be here. So it's a complete honor. Thank you for that very kind introduction. Had an absolutely wonderful time yesterday meeting members of the division and other scientists sort of across the institution. It was a fantastic day with fantastic people, and I'm just delighted to be here again and honored to be presenting the Towery Lecture this year. So my talk is entitled Metabolic Mayhem, Environmental Drivers of Disease and the Need for Clinical Action. And so what I'm going to do for you today is really provide a 30,000-foot view of the links between environmental factors and disease, with a real focus on diabetes, which is sort of my area of greatest interest. And we're going to focus on plastics today because they are the sort of class of chemicals probably that are getting the most attention and most relevance in terms of public policy at the moment. By way of disclosures, I do some consulting work for CVS Health. It has nothing to do with what I'm going to talk about. I do some community engagement and related research as well. So there's this Naperville Environment and Sustainability Task Force and the Clean Energy Alliance of Naperville that actually has a Kentucky connection that we can talk about a little bit later if anyone's interesting. Do some stuff with the Food Packaging Forum as well as multiple groups with the Endocrine Society. And probably the most important disclosure today in 2025 is that I want to make it very clear that I am here in my capacity as a faculty member at the University of Illinois, that the views I express are my own and do not necessarily reflect the positions of the United States government or the Department of Veterans Affairs. So Shri mentioned the mission of my lab is really to understand how humans alter the environment and how those alterations impact human health. But as a physician scientist, this is really driven by the ultimate goal of translating this knowledge into action to protect metabolic health. And so today we're going to talk about sort of diabetes as a disease that's amplified by plastic. So we talk about things like underlying genetic risk, we talk about physical inactivity, we talk about diet. But what I think is grossly underappreciated and what I want to emphasize today is the connections with environmental factors, including those that come from plastics. So for this audience, you may be well aware that diabetes is a disease with immense individual and societal burden. So diabetes currently afflicts 537 million people globally, with 783 million projected to have the disease by 2045. And importantly, this disease burden and this rise is not uniformly borne across the globe. So the fastest increases in diabetes rates are projected to occur in Southeast Asia, the Middle East, and North Africa, and sub-Saharan Africa. Diabetes is a disease that affects the individual tremendously. So it is the leading cause of adult blindness, kidney failure, and non-traumatic amputations, as well as a potent driver of cardiovascular disease, which kills somewhere around 2/3 of people with diabetes. And the economic impacts of diabetes are absolutely staggering. So it's currently estimated that nearly $413 billion in economic costs can be attributed to diabetes in the United States alone, with that cost projected to rise to be over $1 trillion globally by 2045. So this is a disease that's important for the individual. It leads to huge disparities around the globe, and it's immensely costly to the healthcare system. So what drives these diseases? So for a long time, we thought that this was driven by genetics, diet, physical inactivity. But what's important to recognize is that when we look at the rise in diabetes rate, shown here in red from 1958 to 2008, genetics doesn't explain this increase in disease risk. And so the other aspect of this also is our understanding of those factors that do affect that risk has not stemmed the tide in any way. This exponential increase in diabetes rates has continued to this day. And so the question is, are there other factors that could potentially be contributing? So also in this slide in blue is synthetic chemical production in the United States from 1938 to 2008. And that dip that you see in 2008 here is simply the economic downturn. Those numbers continue to go up thereafter. And so it's interesting to see that these two curves are completely concordant with one another. And this is clearly just a correlation. But the question that this raises is it possible that these two phenomena are actually mechanistically linked? And so, and if so, is it possible that addressing the environmental drivers of diabetes could improve metabolic health and stem the tide of the diabetes epidemic? And so that's what my lab has been focused on for a really long time. When we talk about what these synthetic chemicals are, what we're talking about are many, many different chemicals. So it's estimated that there probably are over 100,000 different chemicals in consumer products and in commerce in general. These include chemicals used for food production, like agricultural chemicals, food additives, packaging materials, pesticides, those chemicals that are generated through industrial activity, those chemicals we choose to put on our body through personal care products and home care goods. And then there's a special case of medical care in which we are exposing our patients to chemicals as well. So we can think about those as the active ingredients in medications, but what about all the other things that we're exposing to our patients to? And importantly, many of these chemicals that we're talking about across all of these classes are associated with plastics. So you may know of things like bisphenols and phthalates, but these include things like perfluoroalkyl substances, flame retardants, dioxins, UV stabilizers, toxic metals. There are many others. So when we're thinking about this risk, what we're talking about are exposures across multiple classes of chemicals through multiple vectors of exposure. And so for this audience, I think it's important for us when we think about diabetes as sort of the disease to kind of focus on as we consider what the potential environmental drivers are, is to recognize that diabetes is a disease that's defined phenotypically by elevations in blood glucose levels. And because it's defined phenotypically, there are many different roads to Rome. And so we know that this from just the fact that diabetes is really a constellation of different diseases with different manifestations. It's easy to recognize that when we consider type 2 diabetes, which is driven by insulin resistance, obesity, sleep disturbances, and contrast that with type 1 diabetes, which is caused by destruction of the pancreatic beta cells. There are also monogenic forms of the diabetes, gestational form of the diabetes, which afflict about 14% of pregnancies around the world. But all of them have at their core this failure of insulin secretion matching the degree of insulin resistance that an individual experiences. So when we consider this on the curve on the right, this is from a graph that was made by Steve Kahn that I really like, that we adopted for this paper in Diabetologia. Most folks maintain blood sugars in a very tight glycemic range by matching insulin secretion on the y-axis with insulin sensitivity on the x-axis. And so if you move from point A to B because you find religion, you start exercising, you have your vegan diet, your insulin secretion goes down, and that maintains blood sugars in the normal range. The problem is that most of us are moving in the opposite direction. Our diets are poor, our physical inactivity is less, we have sleep disruptions, we become more progressively insulin resistant as a consequence, and our body has to make more insulin to maintain blood sugars in that normal range. In the short run, that's fine, but in the long run, this leads to beta cell failure, ultimately during periods of peak insulin demand, and one develops impaired glucose tolerance, and ultimately even during periods of fasting, and an individual develops frank type 2 diabetes. So what does this have to do with the relationship to these chemicals that we're exposed to? Well, if we actually look at all the evidence across the literature over the course of the last 15 years, a tremendous amount of data has been generated showing that a variety of different chemicals acting through pathways we know are associated with insulin resistance can promote that reduction in insulin sensitivity. Similarly, a number of different studies have shown that a variety of pollutants acting through known pathways of insulin secretion can impair insulin secretion. And this data comes from cell-based studies, animal models, population-based studies, as well as some clinical studies in which people have actually been exposed. And so many of these chemicals are actually associated with plastics. So these include common toxicants working through well-characterized pathways supported by data across the evidentiary spectrum with potential additive or synergistic effects when we consider that each of us is not exposed necessarily to one chemical, but a mixture of chemicals. So you can start to think how underlying genetic susceptibility plus poor diet plus physical inactivity coupled with a little bit of panel A here and a little bit of panel B here may be sufficient to drive disease development toward glycemic deterioration and the development of diabetes. So the point here is that this is a phenomenon that's occurring at the population-based level that's effectively death by 1,000 metabolic cuts. And so what's the impact of this? So the question is, like, what does this really mean from a disease risk standpoint? So this is a difficult thing to ascertain because the precise impact of plastic-associated endocrine disruptors is likely individualized. It needs to be individualized because each of our exposures and clinical covariates vary. But in recent meta-analyses, it's pretty clear that when we look at those folks who are most highly exposed compared to those with the lowest level of exposure, the risk is real. So for bisphenol A, the odds ratio of diabetes is about 28% higher for among those with the highest versus the lowest exposure. For phthalates, it's almost a twofold increased risk. For PFAS, it's about a 10% increased risk of gestational diabetes. For PBDEs, which are flame retardants, about a 32% increased risk. And for dioxins, nearly a doubling of the risk of diabetes. And as I told you before, this is reductionist in that we're only looking at a single chemical at a time, despite the fact that we're exposed to many of these things. And so these associations are somewhat undercounted because human exposures are mixtures. We don't account for the full spectrum of exposure in these clinical studies, and the impacts during unique windows of susceptibility are not accounted for. And the other thing that's important is that while these chemicals are associated with diabetes, they're not just associated with diabetes. These chemicals are also associated with other adverse outcomes from a metabolic standpoint that includes obesity and being overweight. It includes things like fatty liver, but it also includes things like cancer, neurocognitive disorders, and psychiatric disorders as well. So when we think about the global burden of these chemicals on human health, the impact is likely significantly greater. So I got this question from a patient who called me a few months ago and asked, he's like, this is a vet, and he's like, Doc, I know I've been exposed. So he was exposed to Agent Orange during Vietnam. And his question to me on the phone was, I want to know what this means for my kids and grandkids. And what's interesting about this question is it's really rooted in some good science. So what we know from the literature on environmental exposures and any of these health outcomes is that there are unique windows of susceptibility in which an exposure or other insult portends the development of disease later in life. And from an endocrine standpoint, this has to do with the fact that hormones don't just act activationally on receptors, but during critical windows of development, they're critically important for the organization of tissues. And so what's important with this is that some of these exposures occurring in early life lead to an increased risk of later life. Furthermore, there's evidence to suggest that some of these exposures lead to an increased risk of disease that is heritable, that can be passed down not only to the generation exposed, but to future generations as well. And so the risk with this is that when we fail to act, when we fail to address what these exposures are doing to our health, this is a multi-generational harm. And when we look at data that projects out the likelihood of developing type 1 and type 2 diabetes in children, it's hard to imagine that some of this increased risk over time isn't related to some of these ancestral stressors that are coming from these environmental exposures that may be perpetuated across generations. And while that data is still emerging, it's important for us to consider that what we do now has impacts not just in the moment, but in the future as well. So the other thing about this that sort of sticks in my craw a lot is that this is really an issue of injustice. So we've known for a long time that diabetes is the disease of social injustice, that if you're Black in America, Hispanic, Latinx, or Native American, your risk of diabetes is significantly higher than it is if you're a non-Hispanic white in America. And what's important is that this is not just disease prevalence, but this is also the complications of the disease. This is the kidney disease. This is the retinopathy. This is the neuropathy that goes associated with this. And what's also important is it's the most important complication, and that's mortality. If you're Black in America, you're 2 times more likely to die from diabetes than if you're non-Hispanic white. And importantly, these racial and ethnic disparities are not just based on race and ethnicity, but income matters matters here too. If you're poor in America, you're similarly screwed. And so the question is, how do we address these disparities, knowing that they've existed for a long time and our interventions to date have been insufficient to achieve health equity? So we've done a few analyses of this to try to look at these chemicals that are associated with various diseases. So we've done this a couple of times now, focusing on diabetes, but we recently published this paper in the Endocrine Clinics of North America, in which we've looked at a bunch of different endocrine disorders as well, and shown that many of these vulnerable groups have endocrine disruptors. And so when we think about how we're going to address these health disparities, I think it's critical that we also consider what environmental exposures are contributing to these as well. And so when we think about this disease, when we think about diabetes, in some respects, there's never been a better time to be an endocrinologist, right? This is a very exciting time because we have all of these amazing drugs that we can really help our patients. We can help them lose weight, which is just like this godsend in terms of building patient-physician trust. And it really makes a difference clinically. We have these great algorithms that tell us that, you use these drugs, we know we can reduce the risk of cardiovascular disease, we can improve the kidney outcomes, we can do all of this amazing stuff for the patients. But the problem is that these medications are increasingly expensive, that we have a rising burden of disease, and there remain persistent disparities in who gets these medications. Even at the VA, there's pretty robust data to suggest that our best agents, GLP-1 receptor agonists and SGLT2 inhibitors, are less frequently prescribed to our Black and Latinx populations. And so we continue, while these drugs are immensely powerful tools, we are not adequately using them, but when we do use them, we know it's really expensive. So the question is, could there be a better way? And could this way have broader benefits? And what I mean by this is, if we're talking about environmental exposures that are critically important for developmental programming and the long-term risk of developing diabetes, obesity, thyroid disease, fatty liver disease, but that also contribute to infertility, cancer, neuropsychiatric disorders, and cardiovascular disease, is it not reasonable to suggest that maybe cutting down on these exposures could have highly cost-effective benefits across a spectrum of different diseases? And that's what I'm proposing for you today. And this gets at this idea of prevention. How do we get to a point where we're not developing these diseases in the first place, as opposed to trying to treat them in the most expensive American way at the end of it? So I would argue, this is an important issue for society as a whole, but we're kind of complicit in this in ways that I don't think people fully recognize. And so we had worked with an ethicist at the University of Illinois to really think about what the implications are of this science for those of us who practice clinical medicine. And the reason for this is that we as healthcare providers expose our patients to plastics all the time, yet we rarely, if ever, discuss those risks. And if we think about this sort of within the framework of medical ethics, this lack of discussion, this lack of engagement on these issues really violates core ethical principles of beneficence, non-maleficence, justice, and autonomy. And I'm not saying that it's necessarily our fault, because I don't think we as a field know about this enough. But once you know about it, you really do kind of wonder whether there's a better way for us to discuss it. And this is really kind of important. Now, modern medicine is amazing, and I don't mean to degrade what we're doing here. Like, what we're able to accomplish is a miracle. But how we do it does have consequences, and there may be better ways. So this is just a study that recently came out. This is something that's known. So if we think about the major advances that we have made in medicine, the fact that we are able to care for children in a neonatal intensive care unit and help these kids survive is amazing. But in doing so, we expose them to a ton of plastics in the process. And the question is, is it possible that some of this has adverse effects? And so there's been a ton of studies on this and suggesting that these kids who spend time in the neonatal intensive care unit have high levels of plasticizers in their blood. And the question is, what are these potential long-term adverse consequences of this? And this is an interesting study because it came out recently after the EU restricted use of diethyl hexylphthalate in medical devices. And what they found is that despite this, many of these kids still had very high levels of plasticizers, including new plasticizers that had not previously been studied in the same detail in the same context. And so about 57% of neonates had at least one exposure that may have detrimental effects on long-term development. And I'm not, just let me be entirely clear, I'm not saying we need to close down the neonatal intensive care unit, right? The question is not about whether what we're doing medically is not right. The question is there a way to do this in a way we get all the benefits without the potential downstream risks of this? And it's not just the neonatal intensive care unit. So this was a cool study that came out relatively recently in Environment and Health that looked at microplastics, which are getting increasing attention. And so they did this study in which they looked at crystalloid, and 1 liter of crystalloid leads to the generation of 7,500 microplastic particles that are infused into people's blood with each liter. And this is after it's filtered out through the normal filters that are used before people get it through the IV. And so these microplastics are interesting because they're getting an increasing amount of attention. So when anytime lately anyone looks to see if there's microplastics in human tissue, they're found. So this is just, and it doesn't matter what like news source you read, right? So if it's The Guardian, NPR, if it's People magazine, or it's The Atlantic, there are stories about plastics and these microplastics to which we're all exposed, right? So the story is it's a credit card a week that each of us is consuming. And what is the consequences of that? What does that actually mean? And the reason that I bring this up is that our patients are starting to ask, right? So our patients are increasingly aware. So we need to be prepared to answer these questions. Because they're bringing them to the exam room. As me with more hair back in the day. Okay. And what's important is it looks like these microplastics might be important. So this was a paper that was published in the New England Journal of Medicine just last year, looking at folks who had carotid endarterectomies for non-symptomatic disease. They looked at microplastics in those plaques, and then they followed those individuals over 34 months to basically see if they developed major adverse cardiovascular events. And what they found was that in those individuals that had micro and nanoplastics in their plaques, they were 4.5 times more likely to have a major adverse cardiovascular event over that period. Now, this is just one study. Certainly issues with confounding and causality and all of those types of things, but it's certainly provocative and warrants further study that, that this is something that we need to be concerned about and do something about. I want to make sure that when we talk about plastics, it's important to recognize, and these chemicals in general, that this is one environmental threat that intersects with many other environmental threats. So plastics are a source of many EDCs that are linked with metabolic dysfunction, but they're produced from fossil fuels. So at their core, plastics drive climate change. So we did this, we were asked to do this scoping review looking at diabetes and climate change that we did for the Journal of Climate Change and Health. And I just finished the proofs on this, so it'll be published soon. And so the scoping review basically assessed, what do we know about the linkage between diabetes and climate change, the bidirectional linkage? And so what we found is that for individuals with diabetes exposed to extreme temperatures and natural disasters, which is what we were restricted to, climate change is associated with worse glycemic control, increased mortality, and greater healthcare utilization. So greater number of ER visits and hospitalizations. And that there were key data gaps. These key data gaps included a lack of data from low and middle income countries. Those same countries that I just told you are going to experience the highest rates of diabetes increase over the course of the next 30 years. that the climate impacts on diabetes-related complications and non-glycemic outcomes have not been studied. This is really important because when we think about who's vulnerable, it's going to be the folks with kidney disease, it's going to be the folks with autonomic neuropathy that aren't able to regulate temperature. So this is a particularly vulnerable group of individuals. And we need more data on pediatric, gestational, and type 1 diabetes, with type 1 diabetes being particularly vulnerable because of their absolute need for insulin and challenges with insulin storage that can arise from disruptions in electricity or dislocation. And I would argue that we need to talk about this so that we're prepared for what's coming. And we can't abide by nonsense that tells us that we should not talk about these issues, that we need to have these conversations and we need to be able to do the science if we're going to protect our patients. So this nonsense about not being able to talk about climate, to not be able to do research on climate, ain't serving anybody. And we need to, I think, vociferously speak out against willful ignorance because we need science, not silence. Okay. So what are we going to do? So, so this is the thing, like, they call me Dr. Gloom and Doom sometimes. Like, so the question is, like, what are we going to do about this? And the thing is that we've got power. There are things that we can do. So the National Center for Complementary and Integrative Health held this symposium last summer, and it entitled Complementary and Integrative Interventions to Prevent and Mitigate the Effects of Endocrine Disrupting Chemicals. So it was a little disappointing that NIEHS didn't host this, but I was really excited that we're starting to have this, because when you work in this field and you spend all your time just showing that things are bad, it can get kind of depressing. So we want to, like, sort of move in a direction of what do we do about this? Like, how do we potentially act? And so we had done this analysis that we're working on getting published, in which we looked at clinical practice guidelines for metabolic disease. We reviewed 60 cardiometabolic clinical practice guidelines from 2007 to 2023. We're trying to update that right now. And what we were asking is, how is the environment incorporated into these clinical practice guidelines? We've seen this explosion in data. How does that translate into what we're told as physicians is best practice? And what we found was that there was, a lot of non-specific discussion of the word environment. This is like, it's really hard to even conceptualize what we're talking about, but none of it is related to chemical exposures. None of it is related to some of these risks that we specifically talked about. And there's really minimal mention of any link between exposures and disease. But what's interesting is that there's a little bit of a contrast, because when you look at the metabolic disease clinical practice guidelines, there's no mention. But when you look at COPD and asthma, there are mentions, because we know that air pollution is related to lung disease, right? So the foundation is there. We just have to make the linkage to these other diseases, whether that's rheumatology or whether that's metabolic disease. We need to just make the links that other folks are already making. And importantly, there's really zero mention of individual level interventions to address adverse cardiometabolic impacts of endocrine disruptors. So in light of that, we've written a couple of papers here about how we can undo the undue burden by helping patients and others sort of understand what tools they may have to act. And so we've written these papers a couple of times. One came out last year, sort of saying, like, what can we tell our patients? And there's tables in there. So these are open access. Anybody interested, please feel free to share with your patients. Had a discussion with the endocrine fellows yesterday about a patient who had concerns about this, and I hope these are useful resources. They basically fall under various different spectrums. We're talking about a lot of different chemicals that have a lot of different, chemical properties. But the primary goal with these individual interventions is to reduce exposures. Obviously, that's sort of the cornerstone of environmental health. But there's some other things we can do, like modifying intake of nutrients to decrease absorption, things we can do to mitigate the impacts, and then other interventions like high fiber diets and those types of things that may facilitate excretion of some of these endocrine disrupting chemicals as well. They have various effects based on whether they work on persistent or non-persistent pollutants, but there's some suggestions here. Now this data ain't great though. These aren't clinical trials in the same way that we think about drug trials, right? This is scouring the literature for small case reports and case series, but I think it at least gives us a foundation upon which we can build. But the important thing is individual solutions for systemic problems are not a viable long-term society-wide solution. So what's critical here is that many of our patients don't have choices. Like many of the things that are recommended are expensive and our patients can't opt for them. It's also not always clear what options are good. Many of the things that we choose to put in our bodies aren't labeled with what their contents are, so we don't even know what we're exposed to. Sometimes interventions don't work. Sometimes benefits are not documented. There aren't a ton of studies, maybe none, that show that if you reduce an exposure, you improve a clinical outcome. We have not sort of gotten the evidence to that level of cause and effect. And then the other aspect of this is that's critical is that risk develops across a lifetime. And as I told you, some of these endocrine disrupting chemicals exert their adverse effects early in development with later life consequences. The exposure may be removed from the time that you're actually interested in doing your intervention. And the horse may already be out of the barn at that point. And so the sort of final conclusion here is that, my patients and I don't always have the tools we need. And so as a consequence of that, when we think about what we're asking our patients to do, it's like the kid putting their finger in the dike, right? This wave of plastics that's sweeping over the world and these chemicals that we're pumping into the environment, we're asking our patients to do something that's not possible. Like we can feel like we're able to control something. We want to feel like we've got some agency, but the only agency is really in policy level interventions. So how are we going to do this? How are we going to protecting health for all? So our North Star has to be regulatory systems that benefit everyone. This is the only way to do this in any just way. So the most efficient and just approach for addressing the health threats of endocrine disruptors is through public policy and regulatory action. And critically, this has to be action that spans geographic boundaries. Chemicals do not know borders. They spread globally and they need to be treated as such. Unfortunately, our current political and economic systems really fail to protect public health in this way. And I wrote this slide before January 2025, so you could imagine that there need to be a few more exclamation points after this. It's also critical that we actually demonstrate that we can do something about this. So this was, I thought, a fascinating study about climate change that was conducted by the Center for Countering Digital Health. So this was published in 2024. It's called The New Climate Denial. It's open access. Please take a look. What they did is they analyzed YouTube videos for evidence of climate change denial. And what they saw was this shift over time in what those videos were saying. So the old denial, the old school videos would say climate change isn't happening and humans aren't responsible. The new denial, shown in red, is that the effects are beneficial or harmless, that climate science is unreliable, but critically, that climate solutions don't work. So where this denialism is going is you're screwed and all of these things that are being proposed won't work. It's critical that we show that these things actually do work because they do. And that's whether we're talking about chemicals or whether we're talking about interventions to reduce greenhouse gas emissions, interventions do work and we cannot let this spread because this is like nihilism at its absolute worst. So there's really a need for us to demonstrate that action is possible and that it matters. But we need leadership on this. And so when I give this talk to environmental health folks, one of the questions always that always comes up is, where are the healthcare providers? So we're talking about what these exposures do to patients. We're talking about their associations with diseases across sort of the spectrum of medicine. Why are doctors not speaking out more about this? And this is sort of the call that I think fits with why we're here today. And so in reading about Dr. Towery, there are a few things that jumped out, and I have no idea what his politics would be or work, but there are a few sort of themes that came from sort of reading about him. One is this dedication to teaching. The second thing is the commitment to excellence. And the flip side of this is a career cut short because of illness. And I think there are a few lessons from him for us today that include recognizing that our job is really to prepare the next generation to address the emerging threats to health here around the globe with attention to justice across socioeconomic, racial, and ethnic barriers. But we are not guaranteed time. We do not know how much time we have on this earth to make a difference, and so we have to act now. And I hope that's something that's in line with what Dr. Towery would think. So as I said, individual action is not the primary solution to system problems. So what are we going to do about this? So as healthcare providers, it's critical that we educate our patients, we educate our students, we educate our residents, our fellows, and our colleagues about environmental health. We also need to engage our professional organizations. These are the folks that are writing these clinical practice guidelines, and we need to encourage their advocacy to address environmental drivers of disease. We have, in the Endocrine Society, been very proactive about this. But again, these chemicals are linked to diseases sort of across the spectrum, right? We need other organizations. And when I talk to endocrinologists, they're like, ain't that many of us. Like, we need other people to sort of rise to the challenge and be allies in this fight to improve environmental health. We also have to be vociferous advocates for science-based public policy. That includes ensuring that chemicals are evaluated for their health effects. From an endocrine disruption standpoint, this includes not just looking at androgen, estrogen, and thyroid hormone disruption. This includes looking at things like metabolic and other risks. We need to prioritize human health over vested economic interests. And we certainly need to eliminate the use of chemicals that increase morbidity and mortality. The Endocrine Society is your home. You are welcome, even if you're not an endocrinologist, to join us. We have a special interest group focused on endocrine disrupting chemicals that could be very interesting. I've included Sophia's email here. Hopefully she doesn't mind, but can sort of guide you in the right place. Check out the website for certain to see about our activities. But these are fraught times, right? There are a lot of things that we need to protect and advocate for when health is under threat. So I would argue that we really do need to be an advocate for the most vulnerable. This includes protecting transgender health. And there are many other organizations that are focused on this. The key point is there's many things to be concerned about that need our engagement. And what I would argue is pick your lane and go, because collectively we'll cover it all. But find that thing that you're passionate about and dig in hard. Because things don't need to be like this. Like, unlike genetics, we can choose to make our environments better and choose a healthier path forward. So we can and we will do this. So I just want to close with that and just thank my group. I just have amazing people that I work with, super grateful for all that they do, making me smarter and providing all the hard work that goes into all of this. I want to thank our funding, which I'm super grateful for. I want to thank my mentors. I want to thank Shri again and everyone here in Louisville for the just awesome invitation to be here. I've had a great time and hope to continue the conversations moving forward. And then I will leave this up. If you all want to take a picture, take a screenshot, write it down, memorize this, and just encourage you again to be an advocate for the most vulnerable. So thank you very much.
Thank you so much, Rob. That's amazing. A lot of really great information and stuff that we can use. And it is actually one of our strategic plan principles at advocacy. And everyone shows up to the faculty meetings, gets a full dose of it because we're a big believer that our voices should be heard to benefit. It was really wonderful of you to go through this, and you mentioned vegan diet, so I don't have to. That's really my job. But I will ask a little bit about it. You know, tomorrow is the anniversary of that New England Journal of Medicine paper about microplastics and nanoplastics. And it's interesting that the authors didn't go through any endocrine mechanisms. They just looked at cardiac events, and 4.53 hazard ratio is one of the largest in academic cardiology that I've seen in my career. So it's clearly important, and you're making that connection through cardiovascular risk factors, particularly diabetes. But when you talked about how diet can change it and change that to point B on the curve for diabetes, but you also mentioned excretion with fiber. The other question is that the effect of plant-based nutrition on diabetes is so profound. With one paper from last year saying 37% elimination of diabetes within 6 months of a whole food plant-based diet. I have to wonder if you, with all of those chemicals that you were showing us, taking pictures of, was there phytochemicals that'll fight off the like just change how you spell phytochemical? That'll help as well as the fiber. We're thinking about that. There's so many chemicals, and how would you dissect it out? That would be the hard part.
This is a problem. I mean, the level of complexity that comes from the number of different things we're exposed to, how they interact with other things that are natural in our diets and in our environments matter, and then thinking about all the other risk factors that intersect. It's like it's 16-dimensional chess at some point. The question about the phytochemicals is really interesting. There's some data to suggest that things like sulforaphane, which you can get exposed to through cruciferous vegetables like broccoli, Brussels sprouts, those types of things, may upregulate detoxification mechanisms in the liver that may have some effect. There are also the fiber issue is interesting because many of these toxicants, particularly the persistent toxicants, undergo enterohepatic recirculation. So the idea is that if the fiber binds some of these persistent toxicants and then you're not able to reabsorb them, you can actually lower levels. And so there's some data that's been shown, many studies from Japan looking at rice bran specifically as a fiber that can do this. And it may depend, different fibers, different things. There are sort of products from the microbiome that may help also. Things like psychodextrins have the capacity to bind various different chemicals. The flip side of that, of course, is that it may depend on your agricultural products also and how intensively they're sprayed with pesticides. So the Environmental Working Group has their sort of clean 15 and dirty dozen fruits and vegetables that have the highest level and lowest level of pesticides. So there's sort of that counterbalance. There's also been a bunch of studies looking at potential benefits of resveratrol, which is in red wine and grapes and those types of things that might be beneficial in some instances. With many of these studies, they haven't been rigorously assessed in sort of the clinical trial format that we would most be useful for, but certainly maybe some benefits there as well. I mean, oftentimes we're thinking about these chemicals inducing things like oxidative stress. So those things that, you get from your diet that are antioxidants may be helpful. We're particularly interested right now in also vitamin D, not as much diet, more sunlight, as something that may attenuate some toxicity as well through this mechanism of cellular uptake. So I think the point that you're making is right. I think these exposures are happening at the same time our diets are deteriorating, and it's going to be a little bit of panel A and a little bit of panel B with important crosstalk between the two. And what's interesting then when we think about it is if we improve our diet, can we simultaneously address the second risk factor at the same time, right? And so those kind of interventions are particularly interesting to me because you get sort of a positive feedback loop in terms of benefit. And so those are really areas I think we need to do a lot more study for sure. So your point's well taken.
So, when we're sitting in the clinic, do you have any one-page handout that we can give to the patient and say, which would be like many other things when they come in, thyroid problem or diabetes, we give them the thing and say, hey, do these things.
Yeah, so So we did that. So that's like one of the fun things. So in the presentation, I gave you the paper that we published in Frontiers, and then this last paper that we published in the Journal of Internal Medicine with Leo Trisande. Each of those has a table in it that could easily be just printed out for the patient and includes things that sort of reduce exposure and may facilitate excretion based on the best level of evidence that we have right now. So this is one of the areas that I'm particularly interested in because it's, we do the basic science stuff and that's great, but seeing the patients, like how do we actually translate it? So there's many pieces of advice that are in there. And that's often a question that people ask, like, what are the key things that you need to do? Certainly, and there are even core things, if we can get rid of plastics from our home as best as we possibly can. So trying to use glass containers if people can afford those, certainly not heating things in plastic and sort of taking an anti-plastic approach. That's one great approach. And then I would suggest the avoidance of PFAS is the other key thing. And so, getting rid of Teflon pans and those kind of things, over time, it's been hard even in our own house because these things aren't cheap. So you're kind of rolling them over slowly over time, but making those transitions matter and certainly matter if you've got young kids or are pregnant, even more so. But both of those papers have those suggestions, which I think will be helpful. And then the other thing that's come out that I think is really helpful that maybe folks aren't really aware of is we got kind of the first guidance on clinical practice in these environmental toxicants from the National Academy of Science, Engineering, and Mathematics, Medicine in 2022 when they came out with their PFAS guidance. And in that PFAS guidance, there's recommendations for thinking about who should be tested, when they test high, what are the next steps, and thinking about water purification. And then there's some interventions that are suggested as well. The interventions are a little crazy, but could potentially work. So, yeah.
So do we know the risk, for example, using water bottle like plastic or like even holding vegan food in plastic? What the risk in there? Do we know? We don't know.
Yeah, I mean, I think the water bottles are clearly a threat. I mean, if you're sort of consuming water out of a plastic bottle, you're getting exposed to things like bisphenols. And if they're not bisphenol A, they're going to be a different bisphenol. Because the other issue is like oftentimes we'll like have this advocacy effort, we'll get one chemical removed, and then another chemical will just be put in its place. And as a consequence, we get what are called regrettable substitutions. So for me personally, I mean, I'm drinking out of it now, so maybe this is not the best example, but I have a glass water bottle that I carry around that's got like a rubber outside on it. It's a little heavy, but I need the exercise anyway. So we try to avoid it. Yeah, I try to avoid plastic. The other thing is even aluminum cans. It's all important to recognize that they're lined with plastics also. So this is its own thing. And then at home, one thing we do is we definitely use water filters at home. So we still have a lead service line to our house, so that's getting replaced this year. But in Chicago and in many old urban areas, lead is a huge issue associated with all sorts of neurocognitive and other health disorders. And hopefully, there was a push by the Biden administration to try to remove lead piping to homes, and hopefully that'll continue, although we may have to advocate and fight for that as well.
You had one question, a long comment and a question in the chat area.
No problem.
Dr. Here we'll pull up the chat. It's toward the bottom. It's from Dr. Emmons, right there. That one right there.
Exposure to microplastics is still generally a small mass exposure. However, the type of cooking oil and the exposure of cooking oil to high temperatures, both of which may vary by socioeconomic class, more high temperature frying and lower economic is a mass exposure. There are now many publications about the risk of the method of use of cooking oil and bad health outcomes you discussed. Furthermore, oil supplies are often adulterated in production, especially when supplied in large volumes at low price. How do we adjust for this variable in the analysis of plastics and microplastic exposure? Yeah, I mean, this is a great question. So it hasn't adequately been addressed. I think part of the issue is sort of the products of the heating of the oil as well. But then the other aspect of this is that oils are sort of perfect conduits for hydrophobic toxicants as well. So really understanding this is like going to require more study. So it's an area that I'm not super familiar with, but it's easy to imagine how cooking oils may be an important vector of exposure, particularly if the supply of the underlying ingredient for the production of the oil uses a high amount of pesticides in their production. So this is something that could certainly be a vehicle of exposure and lead to health disparities as well. So your point is very well taken.
If you scroll all the way to the bottom, you get another question or comment.
You mentioned water filters, but these are made of plastics. Do they contribute to leaching of chemicals as well as removing some? Yeah, so the plastic component of this is a little tough because, yeah, plastics are basically in everything. So it's a function of, like, I think, relative risk here. I think the benefits of being able to filter out the PFASs, the benefits of being able to filter out the toxic metals may overlay that. I think, this is one of those things where, what's the attributable risk to the plastic component of the filter versus the other chemicals that are removed by the filter? Also needs some study. I think we've adopted at our house the idea that sort of doing the filter probably matters a little bit more than avoiding the plastics in the filter. But yeah, I mean, it would be great if we had plastic-free solutions there. Ceramic filters would be great. I don't have familiarity with them, but that makes sense. Ceramic is usually one of the best substitutes for things like Teflon-coated pans. So that's what we use in our house. So using them as filters, if they're equally effective, would be good. One of the questions always is, what are you trying to remove? And so water filters vary in terms of what they remove from the water based on sort of how they work. So is it a reverse osmosis system, or is this some type of size exclusion or something like that? There's an area I don't know enough about, but I need to do certainly a little bit more homework. So I appreciate the point.
Dr. McCarter had a comment on propionolanocorticotropin.
Yeah, pro-opiomelanocortin pathway also important and affected by lack of sunlight and exposure to constant blue light technology. So this is interesting. Yeah, I mean, I think if the point is related to sort of signaling through melanocortin receptors and the regulation of metabolism, that makes a ton of sense. And then obviously our lack of like getting out and spending time outside is huge. It's always interesting when you see those studies that show that if you have higher vitamin D, you have better health outcomes. And always the question is, like, is that related to the vitamin D and its effects on the immune system or whatever? Or is that just that people are more physically active and outside? So, but certainly hormonal pathways are certainly affected by sunlight as well. Also circadian rhythms and sleep, also just the importance of like getting good sleep and the adverse effects of that. So, as we dig into this, like, it's clear, like there are many different risks to metabolic health. The point is well taken. This is obviously just one of them. I think I just want to make sure that we're not ignoring the environmental drivers of this that clearly intersect with other factors as well. This is not we need to think about this stuff multidimensionally. So what about the effect of these chemicals on immunity? Yeah, so there's really interesting data looking at PFAS to show that PFAS attenuate the response to vaccines. And so that's on one side. On the flip side, there's certainly activation of immune pathways by some of these. We see an increase in inflammatory cytokines with various exposures as well. So it works in both ways, where you may end up with immune dysregulation that's beneficial, that's deleterious, either because it's overactive as well as because it's underactive as well. So, and we'll see where all these measles cases come out and whether that may be contributing, and PFAS in the water may be contributing. Yeah, and vitamin D definitely may be directly related to immune issues. There's definitely immune modulation by vitamin D. There's colleagues in the audience who probably know more about this than I do, but it seems like high vitamin D is used in a number of autoimmune diseases. There's been a lot of advocacy for things like multiple sclerosis and using higher doses of vitamin D there, where it clearly modifies that risk. And in our own studies, we've shown that vitamin D modifies the relationship between PFAS and cholesterol. So we're getting that paper ready for publication now. So.